This is the appearance of a bronchial lung pattern. Here is normal. There's those three divided. If you imagine seeing them end on, so imagine taking a section right the way through here and looking right the way down the bronchus, we would see two end-on vessels, which are like little circles, and nothing in between because we don't recognize the normal bronchial wall. It's so thin we don't really see it on a radiograph. This is a little clip from a CT, which actually shows this is the artery, this is the bronchus, and this is the vein. So you can see that the gap between the artery and the vein is not actually all of the bronchus, because it lies a little bit closer to the artery than it does to the vein. But from a radiographic perspective, we can't distinguish that. So we often assumed everything between the two is the bronchus. When we see a bronchial pattern, essentially we are starting to see the walls of the bronchus. So these will obviously lie inside the respective artery and vein. And if we see them side on, we see them as two parallel lines, which should slowly taper as we get into the smaller and smaller bronchi. And if we see it end on, we see a ring. So the two terms we apply for that are tram lines or train tracks and end on rings or donuts. And you can see that the Americans with their tram lines and donuts have had an influence on what we call these. We can see increased visibility for two reasons. Either because the opacity of the wall itself has increased, and we know there's only 5 radiographic opacities. They are soft tissue initially, so to move up to the next radiographic opacity, they must mineralize. And so this is a patient that has got mineralization of its main stem bronchi. If you follow along here, there's this fine, thin, linear, very opaque structure that just outlines the main bronchus. We can see here we've got one caudal lobar bronchus, and then we've got the other caudal lobar bronchus coming through here. And if we look down here in the cranial lobe, we can see just lying on the inside of the vessel, we see this fine mineralization, and it's just sitting away from the vein, as we might expect on the CT. So this is mineralized and the wall is not thickened. So this gives a different set of causes than a patient that has increased visibility because the soft tissue structure of the bronchus has become thickened. And actually we see a little bit of mineralization of the bronchus in particularly large breed dogs just as they age with time. We also see it in conditions that have sort of disorders of calcium metabolism, and the one I think we see most commonly would be a patient that has Cushing's. This is actually a Cushingoid dog, and here we've got another example of a Cushingoid dog. We can see again a bronchial pattern, which is just highlighting those bronchi, particularly again around the hilus, the larger vessels and bronchi. When we look closely, particularly in the abdomen, we see other features of this patient being Cushingoid. We can see a pendulous abdomen, reasonable amount of intra-abdominal fat, and this classic enlargement, a slipper-shaped enlargement of the liver as well. So this would be a fairly typical appearance of a Cushingoid patient on radiographs. So in this circumstance, although we recognize there's a bronchial pattern, actually this is not the primary pathology, this is just a secondary effect of it. So important to differentiate fine mineralized bronchi, which will have a certain subset of differentials, from patients that have thickening of their bronchi with the appearance, when you look at this overview, of sort of cuffs and hazy thickening around that bronchus when we see it end on. So we see here a donut, here a donut, and when we look closely we can see tram lines coming down either side of the main bronchi, and then as branches come off of them, they're all little donuts with kind of a hazy wall. If I just blow up the radiograph so you can see the fine detail a little bit better, we can see here thick hazy margins around the walls, and here we see the donuts. And this continues not just around the hilus, as we saw with the mineralized patient, but right the way out into the periphery of the tissues. Here we can see a donut all the way out here. It's less obvious because obviously when we come out to the margins, the bronchi are relatively smaller, but it's still there and shows why it's worth making sure that you increase the size of your or blow up your radiograph if you have a digital image to make sure you look for that extension out towards the periphery that confirms this is genuine pulmonary disease. This patient also, you may have noticed on the larger images, has additional pathology. We can see here a soft tissue nodule, and actually a couple more when we look a little bit closer. And this shows how in the real world most patients don't have just one lung pattern present, which is why that actually starting with the lung pattern is not necessarily the most helpful way of going about prioritizing your differentials. This is actually an example of a patient that has eosinophilic bronchopneumopathy. That used to be called pulmonary infiltrate with eosinophils, which had the lovely acronym of PI, but has been renamed in something that's a little bit harder to say, but I think has perhaps a little bit of a more scientifically appropriate name now. It's an allergic lung disease. We tend to see it in younger dogs. There's a bit of a breed predilection for some of the large dogs such as huskies and malamutes. It always has bronchial lung pattern, and it's soft tissue thickening of the bronchi with a hazy margin that we'd call a peribronchial cuff. But it often will also have concurrent lung patterns such as nodules, which are like little granulomas that form secondary to the allergic changes, and sometimes extension to an alveolar lung pattern as well. Here's a second example where we have fewer of the secondary changes. We can actually just see that we have a bronchial lung pattern, and this is actually the same patient that had been treated after only 6 weeks of anti-inflammatory steroids in this particular circumstance. We can see that we preserved that bronchial lung pattern. However, all of the other changes are resolved, and no longer do we see this extension right the way out into the periphery. There is one hint of a nodule remaining.